place. Now, staffing in the hospital can be pretty flexible, and the amount and type of staffing we have will depend on the show, what we're expecting to see, and also who's volunteered. Let's be realistic. I may want 5 nurses, but if only 2 volunteered, then that's what I've got. I try to have the nurses function somewhat autonomously. When you are assessing a patient, I'd like to see some type of a systems review assessment and sometimes a nursing diagnosis. There have been shows where the doctor has been late or the doctor never showed, and the nurses have been the highest ranking medical authority. Now, it is interesting to note that we can roll a patient to the hospital with a nursing diagnosis, and we have in fact done so. Which brings another point. I was giving a lecture last year on rock medicine first aid for the masses, and someone asked me at what point did we decide to roll a patient. Well, first I thought about it and I said, well, when they're not funny anymore. Yes. And that's not true. The point at which the care that we provide a very high level of care, but we always have to be cognizant of the environment or the setting in which we are providing the care. There are things that we may be perfectly capable and equipped to handle, but in this setting, they're inappropriate. We are capable and equipped to handle the delivery of a baby. But, and here's where appropriate comes in, if you're in Calaveras at the frog jumping place they have up there, the Calaveras Arena or Fairgrounds, and the nearest hospital is quite a ways away, and it's a 1-lane in, 1-lane out highway, and you've got a woman who's dilated to 7 or 8, then it may be appropriate to deliver that woman at the concert. If, on the other hand, you're at the Oakland Coliseum and you're 10 minutes by ambulance from the nearest hospital, it's not appropriate. Okay? So we try to look at the appropriateness of what we're going to do, in addition to just can we do it. We can do just about anything, and the equipment that we carry ranges from basic Band-Aids, aspirins, tampons, pins, needles, sewing kits, to crash kits where we can provide ACLS. We have a defibrillator monitor, but that doesn't necessarily mean that we should provide it. And in fact, if I have no ACLS personnel that night, we do not provide ACLS. We provide BLS and call 911 and let them assume ALS responsibility from there on. Okay, what else? What haven't I covered? Trippers. Trippers. How many of you have any experience dealing with people who have been indulging in the use of recreational medication?
I regulated 2000.
Okay, we may see a variety of street drugs at Rock Medicine. Certain shows, certainly LSD is back, and it's back big time. And you know, I don't even know why I'm saying it's back, because for our purposes, it never left. You know, I don't know where 48 Hours got the idea that LSD had somehow declined in popularity. I don't know, but it hasn't. We have 20 years experience this year, 20 years experience dealing with people taking LSD. And we've discovered a couple of truths. Number one, the LSD today is a little less potent than it was in the 60s, thank God. And number two, sometimes you can help them and sometimes you can't. And what we do with trippers is very, very interesting, and they'll cover that more in Space Station. Barbara. I am? Okay. We'll talk about trippers a little bit more in the space station. Now, the reason I carried this thing over here is I wanted to go over the hospital setup just a little bit. In most cases, this will be the front door, okay? And here will be the intake, or the table service, okay? And that's where the aspirins, the Tylenol, the whatevers are there. Earplugs, okay? Big donation item, earplugs. Boy, people are really...
Kathy, we're going to get you a darker
marker.
A darker marker?
Who has one?
Cancel bar.
Right here.
Okay.
That one's thin. That's like invisible.
It works.
Oh, they can see that?
Oops.
Okay, this will be your table area. And over here, attractively arranged, will be mats, basins, and paper towels. Okay, this is what a patient room looks like at Rock Medicine. There's a mat, a puke basin, and a roll of paper towels, and a blanket. Okay? Now towards the back, and sometimes we're screened off, will be the suture area, and there'll be at least one exam table and the road boxes. The road boxes are places where we keep our supplies. They're great big boxes that were built for us years ago by FM Productions, namely Willie John and Jim Downey at FM Productions. They were a donation and a gift of love from these two guys to it. And they're still with us. They've probably been with us 10 years. Okay, and in the road boxes are packed all of our supplies that matter. The stuff we have to count and the stuff that costs me big bucks to buy. Okay, and it's where the bandages, the ACE wraps, the cold packs, the eye kit. We have an eye kit that contains a supply of eye medications and an ophthalmoscope, some fluorescein strips to check for corneal lacerations, and a blue light. Okay, we have an emergency OB pack in there. And that's where we keep all our backup supplies too. The other road box, the main road box, has the IV supplies, the suture supplies, the ambu bag, the O2 setup, the variety of oral airways, and our pharmacy. Pharmacy at Rock Medicine is very interesting. We carry a surprising variety of drugs. Sometimes it's hard to keep up on the expiration dates of all these drugs, but we do our best. In the future, however, we may not be so fatly stocked with drugs because, like everybody else, we're having budget cuts. And so in order to save money, I'm going to be stocking less of a wide variety of supplies. One of the things we're looking at is we're not going to stock 7 kinds of bandages. I literally have 7 kinds of bandages. I have knuckle bandages, fingertip bandages, giant H bandages, big wide bandages, and little thin bandages. We're no longer going to be able to afford to stock 7 types. 4x4s. I stock sterile 4x4s and non-sterile 4x4s. The non-sterile 4x4 is the workhorse of Rock Medicine. It does everything. It will continue to be the workhorse of Rock Medicine, but I may no longer stock 3x3s and 2x2s because I figure we can just cut 4x4s. Okay? Curlex is another item that I'm looking at maybe we really don't quite need, 952 rolls of Curlex. Because have you ever noticed anything funny about those Curlex rolls? They're always in a variety where you can't use the whole roll on one patient. And so I have like maybe a bag of Curlex pieces. The other interesting use for the bag of Curlex pieces is to tie back the long hair of girls who are puking in a bucket. It's a really nice thing you can do for them.
Yeah, rubber bands too.
And rubber bands.
Oh, sorry.
Rubber bands, you give them a split end.
Sorry. I didn't know.
You don't want to split their ends. Okay? Well, there's one other thing. We also have chem strips, Fiji chem strips. And we do blood sugars on people. And we, of course, do manual reading of blood strips or visual reading of chem strips. People have offered to donate us AccuChecks and the machines you use in the hospital check blood sugars. No way. Because if they donate it to us and we use it, then we have to do QA monitoring, which means we have to certify that all the nurses who are going to use it actually know how to use it. They have to demonstrate proficiency at specified levels, and we also have to test the machine frequently to make sure it's accurate. Now, if you're doing visual readings, you don't have to do that. Of course, I'm sure that in the next few years, OSHA and the Joint Commission will then suddenly decide that all nurses must show proof on an annual basis that they're not colorblind. Okay? For the most part, visual reading is just fine. Occasionally, people will come in and tell us they're diabetics and they'll want to give themselves their insulin in our area. And and we allow that. We give them some privacy in the surgery area and we let them give themselves the insulin. For 2 reasons. We carry appropriate needle disposal units. And very few people these days want to go into a public restroom with a needle and a syringe. And I think that's a great idea. So if a diabetic approaches you and says, I need to give myself my insulin, can I do that here? We do it. Okay? Universal precautions. Ah, yes. How many of you are already familiar with universal precautions? The rest of you aren't. Okay. Universal precautions is a method of using barriers to protect the skin and mucous membranes of a healthcare worker from the blood and body fluids of another person. Okay, and this OSHA requires that we use universal precautions. Cal OSHA requires that we use universal precautions. The CDC suggests that we use it. And the reason I use the words require and suggest, Cal OSHA and OSHA have the ability to legally make you do it. CDC can only recommend it. Okay? Okay, in order to use universal precautions, you need barriers, and barriers are gowns, gloves, masks, goggles, shoe covers. Anything that is impervious, and when I say impervious, it means the liquid can't go through it. So in an emergency setting, if you're in the field and someone is bleeding and you don't have something that will not soak through and get it to your skin, what could you use if somebody had a hot dog nearby that had been wrapped in aluminum foil? You can put your gauze down over what's bleeding, plunk it down, then grab the aluminum foil and put it over it and apply pressure. Aluminum foil is an impermeable barrier. So is Glad wrap, and so are plastic baggies. So if you're on a field team and you've got your 4x4s in plastic baggies, but you don't have a glove, take the 4x4s out, put your hand inside the plastic baggie, and you've got the equivalent of a glove. Now, universal precautions, the CDC says, applies primarily to certain fluids, and those fluids are blood, semen, and vaginal secretions. Thank God most of the time we are not in contact with semen and vaginal secretions as a show. However, I said most of the time. I said most of the time. Now, blood is our #1 risky business body fluid. The other body fluids to which universal precautions apply are cerebral spinal fluid, amniotic fluid, synovial fluid, pericardial fluid, and pleural fluid. And if I've forgotten any body fluids, I apologize. Cerebral spinal. There are certain body fluids that because the concentration of virus in those fluids is so low, you would literally have to be exposed to a quart of them, and namely saliva, that universal precautions is not really needed if you're just dealing with somebody who's spitting. Spitting is a real obnoxious, inappropriate, offensive behavior, but it will not give you AIDS. You do not need universal precautions if someone's just sweating. Sweat will not transmit AIDS or hepatitis B to you. Now, the CDC also says that you don't have to use universal precautions unless blood is obvious when dealing with urine, feces, and vomit. Well, that's nice, and I'm glad the CDC said it, but for aesthetic reasons, I ain't touching vomit, feces, or urine without gloves on. Okay, and I have no problem if you want to wear gloves to deal with those particular body fluids, and yes, we do encounter vomit. And sometimes lots of it.
She will yell at you for taking a whole wad of gloves and putting them in your pocket.
Please, please remember, I'm buying
She'll chase you.
cases of gloves these days. Do not, if you want to carry one pair of gloves in your pocket, and you're on a field team, carry one pair. You use it, you come in, you dispose of it, you get yourself another pair. Please don't put 9 pairs of gloves in your pocket, because you're going to go home with those 9 pairs of gloves. You're not going to use all 9 maybe that night, and you're going to go home with them, and we need them more than you do at home. Okay? And my biggest pet peeve are the guys who wear those pants with all those damn pockets in them.
20 pairs of gloves.
I mean, it first came to my attention that people were misusing gloves when one day we went through 600 pairs of gloves in an hour, and the gates hadn't opened for the show yet. Then I took a good look at the crews, and I noticed they were wearing those wonderful multi-pocket pants, and they all looked like the Pillsbury Doughboy because they had them stuffed with gloves. So certain things, if you're filling out an intake, you don't need to wear gloves. If you're wiping a sweating patient, you don't need to wear gloves. If you're wheeling a wheelchair, you don't need to wear gloves. If you're cleaning up a cut, you need to wear gloves. If you're cleaning up vomit from around a patient's mouth or emptying a bucket, you need to wear gloves. Okay? So use some common sense with your barriers. Now, are there any questions? Anything I forgot? Did I forget anything? Minors, we talked about minors.
Yeah, we talked about that.
Over 18.
Right?
Yeah, we can.
No, under 18.
I mean,
Why?
well, you know what I meant.
Barb's people.
Okay.
Over 18 if consenting adults. Okay.
Talk about doctors should see every patient, don't push the envelope, you know.
If we are not busy, and when I say not busy, I mean not crazy, and we have more than one physician, it is in the best interest of the patients and us that the doctors see every patient. That's not to say a nurse can't do the original workup or you can't do the original workup. Now, there comes a point where maybe we only have one physician and we're incredibly busy. Because remember, the hospital can go from empty to full in a matter of minutes. And I believe, if any of you were at Guns N' Roses, we treated 300 patients in 10 hours.
Something like that.
But we have treated as many as 80 in about 4 hours. Usually it's easy tough. If we are at that point where the doctors are just too busy to see somebody with a minor cut on their finger, then go ahead and have one of the nurses. Just say, yeah, okay, bandage it up and take care of it that way. However, if the person is coming in complaining of an injury to a joint, like, hey, somebody stepped on my foot, or joint or body part, and they think it might be broken, crushed, or otherwise spindled or mutilated, it's important that a doctor see that person, because the doctor needs to do a joint exam. If somebody comes in with a head injury, they've got a laceration on their head, have a doctor see that patient, and if you're a nurse, kind of tactfully remind the doctor to do a quick neuro check on that patient. Okay, so that we have some kind of idea, was there loss of consciousness, yes or no. Sometimes the guy didn't really lost consciousness. C-spining has become a real issue. One of the new things we're starting to see at shows, certain types of shows, is crowd surfing and stage diving. Crowd surfing, somebody gets up on top of the crowd and they pass them. The most interesting issue, crowd surfing, the type of injury you'll see with crowd surfing reminds me a lot of something we saw in the 60s when the jerk was a very popular dance. When you have somebody who's being crowd surfed, he may or may not be conscious. He or she may or may not be conscious, number one. They're being passed over the top of people at a crowd, and sometimes they're dumped over a barrier. Now, one show, we did have a young man come in with a subluxation of his vertebrae between T3 and T4. And there it was critical to maintain appropriate positioning and C-spine with that guy. So that nowadays, we do C-spine people who are victims of crowd surfing or stage diving. Okay, and that is a change because before we were very limited with doing C-spine. All right? I think that's it.
That's it. All right. Thank you, Kathy. Very good. Visual aid. Just a couple add-ons. The gloves thing is important too, because if you got a whole team that everybody's got gloves or just standing around with gloves on, it doesn't make us look good either. We're trying to make the patient feel comfortable, letting know that we're not afraid of the patient. You know, that's part of what we try to do. So that's important. And included in that, when we talk about the pants, so we haven't mentioned the uniforms and stuff. We try to stray away from rigged uniforms, that kind of thing. If you want to wear the rigged pants, okay, have a pair of tennis shoes on or something, and a medical shirt, something like that. The big jack boots and stuff with the big blue pants or the camouflage pants and stuff like that really doesn't make it. It scares the patient. So we had, wearing black leather gloves, that kind of stuff. Having one patient say, "Is he here to help us or is he trying to hurt us?" So.
One more thing about the gloves, don't put your gloves on ahead of time, folks, because what happens after you wear gloves for 20 minutes?
The wrong way.
Your hands sweat. Once that happens, you've reached the effectiveness of the glove. Okay? Sit down, put your gloves on, and stand around waiting for the first patient. Just put your gloves on at the point at which you need it. If someone is bleeding and you're really in a hurry to apply pressure, throw the glove down on the spot that's bleeding and apply pressure over the glove. Okay? Because sometimes when I worked in critical care, somebody would just pull their art line out. I didn't have time to put the gloves on. It was a question of laying the glove down and sit on it and yell for help. If you are assisting someone who is dealing with someone who's bleeding and they're not wearing gloves, if you're going to help them, you put on your gloves first, you relieve that person then goes and washes his or her hands immediately. Okay?
Okay, thanks. We're doing pretty good. If you have to go, a couple people already talked to me. If you have to go for prior engagement, feel free. And then we can talk about what you might have missed at a later time. Okay, up from LA to visit us is Angie Rice. She's the dugout coordinator. She moved down south here just this last year, and we miss her greatly. It's nice to have her back. And she's the dugout soup, and she'll tell you what the dugout is and how it works and how it pertains to the indoor shows as well.
Oh, okay.
Because they're all basic
I'm
skills.
kind of surprised that you're doing this, guys. Okay, I came over here to say hello to everybody, found out I'm doing this. So,
Right place at the right time.
right, I happened to show up. Okay. Dugout. First of all, I'm really not the dugout supervisor anymore because I live in LA and I can't be there and do it. So Barbara Horn is really doing that, and she'll be out here in a minute to join me.
Sorry.
Dugout is really mostly found at the really big shows, like Oakland Coliseum, John Dreams. This is the most common one.
Where there's a dugout.
Huh?
Where there's a dugout.
Where is the dugout?
Have to play baseball.
Huh?
Wherever you play baseball.
Wherever you play baseball. And we have a show. But there's also, we call this outdoor area where we're right with the crowd a dugout, even if we're not in a baseball stadium. I mean, if we're at some outdoor venue elsewhere, and there's an indoor tent inside where people go to get help. And we also have a crew out in the field someplace, stationary crew out in the field someplace, that we also we call the dugout. It comes from the Coliseum. The dugout is basically set up to deal with minor cuts and bruises as a triage area for the indoor hospital area or space station. We have all kinds of people that work in the dugout. We can be licensed medical staff or unlicensed staff. We do paperwork just in the dugout, just like we do anyplace else. We do major amount of table service in the dugout. Basically, we're the most visible of the RockMed people, and everybody will gravitate to us for help. But also at the dugout, there will be a communications person who's in touch with the hospital area, either by telephone or radio. There will also be an emergency team who can go out on calls. When we don't have a giant show, we function along with, in any show, in any venue, at any time, doing a variety of things. I mean, when I work at the other shows, I might work in the space station, which Barbara will talk about in a minute, which is mostly trippers or people who need to be watched for wild drugs. Or I might be helping with people who come in with minor trauma, stubbed toes at bed shows, lots of feet injuries. I get to do that. Or I might help with table service. Or if the hospital is understaffed, I may help in the hospital.
You know, the dugout is essentially, what's nice about the dugout is the triage area from the main green at the outdoor shows, and you get a lot of patron contact. It's a great place to be. I used to be in communications way back when with Andy in the dugout, and the interaction that you get from being there, you're very directly on the green. So people are coming up, they're asking questions, where's the water fountain, what can they do? So it's really nice interaction. You learn skills that help you out at the indoor shows. If you're on break, if you're standing out in front of the door of the medical room or something, it's that same thing. It's that interaction with the crowd that the dugout really does help develop, because you have to deal with all kinds of people, and they'll come up and ask you everything. You know, and even if it's not medical, they expect you to know, or at least direct them, appear like you know, and direct them in the right place. So those are some of the skills that you get out of the dugout. And it can be a lot of fun. It's very loud, but you learn those interaction skills that are real nice, and that's what a lot of fun is, because watching the crowds and talking to the crowds can be as much fun as anything else.
So typically what you would expect if you came to a day on the green and somebody said you were assigned to the dugout is you would find Barbara down there who would be who would be in charge, and she would ask everybody to meet down there for a meeting before the music starts so that she can be heard. And she would explain to you what her expectations for that day are. what we will expect to see and how she wants people to work together. We keep a couple of trunks down there with all kinds of bandages and ace bandages, and we have Gatorade or whatever, whichever fluid we're using currently. We have aspirin, Tylenol, all that stuff. So it's hard to take a blood pressure, but you can if you have to. And we just basically make a decision about whether we can treat the person there and send them right back to the concert, or whether they need to be transported inside to be seen by doctors and nurses who have more equipment at hand and can watch them more carefully. Any questions?
All right.
Go ahead, Ben.
Thank you, Andy. Andy, she literally doesn't feel like she's had to give that talk, and she's done it before.
I'm
Andy
saying
and Kathy, did you want to come up as well?
No,
For the psych thing?
For the space.
Okay.
She'll just wait then.
Yeah, we're going to have a kind of a group discussion for the psych part, the space station. Before we get into that, while they're getting organized, another aspect of what we do at the large outdoor shows is we have the communications network, which isn't quite as evident as the smaller shows. The large shows will have central communications in the press box. They're linked up by phone to the emergency teams on stage left and stage right. They're linked up to the dugout, the hospital, and they also monitor the radios. So there is a pretty nice communications network that's been set up, especially at the Oakland Coliseum Stadium, where we cut our teeth and where we really, that's our place, really know how to handle that place. So now, what's it, I tripped and I can't get down, dead alert here? This is
falling and I can't get up.
Go for it, ladies.
Usually who runs the space station is Steve Anderson or Don Kantner or Gene Sheen. Or Jack Mikowski. Okay, basically what the space station is people that are tripping on acid or, a chemical substance which is most likely illegal, alcohol, and then a lot of the space station patients or people that have the flu and don't want to hang out for the rest of the show, but their friends do. What Andy was talking about with the dugout is somewhat the same in a closed situation where it is a triage center. When a team brings in somebody that's tripping, supposedly, you're assuming that this person is tripping. When they come in, there is either a doctor or an RN that will pretty much kind of make the decision, maybe this is a space and not an emergency situation. And in that situation, we take over. The thing to do is if you've never tripped on acid, is to maybe sit and watch somebody that is tripping on acid, or ask people questions that that have tripped on acid. Ask them what kind of effect they get. Yeah, right. See, the best thing is for yourself and the patient is to know exactly what they're going through. For me, I believe that there's 3 levels when you're working with a patient that is on, just some LSD or ecstasy or marijuana. Some people get paranoid and tripping out on a pot. I believe that there's 3 levels. There's one where you're approaching the patient and the patient is, paranoid. He's afraid of what's going on in his body. And you approach that person like you're in control, that you're explaining to them what's going on so they can forget what's going on with them but concentrate on what you're talking to them about. And, that you are in control because they have lost control. And then there's patients where you want to go at the same level with them. You are equal to them. It's like whatever they're talking about, you're agreeing with it. You're saying, "Wow, man, I can relate. I've been there," even though you haven't been there. And then there's ones where you basically are inferior to them. It's where you're basically kissing their butt. They think you're kissing their butt. They're telling you you're fucked. You don't know how to relate to the human, race. It's like, and you go, yeah, you're right, I don't. And it's just, because otherwise you're going to get a patient that's going to say, they're going to get violent. A lot of times we do have violent patients. And in that situation, it should be the space supervisor that makes the decision whether this person needs to be restrained or not. We restrain by, for the safety of ourselves and other patients. And for patient itself is we make the decision whether it's leather restraints. It depends on how much staff we have also. Or if we restrain that person by manual means such as our bodies.
Which we prefer.
Yes. We do not restrain with handcuffs. Anybody that has handcuffs, do not bring them. You don't use them here. That's one of the things is we do different from, hospitals and institutions and, ambulance companies basically, is our approach is different. We are not going to be a threat to that patient. Our basic thing is to get them together, whether it be 2 or 3 hours later, get them with their friends and go home safely. Otherwise, they end up in jails or they end up in psych wards of hospitals, and we don't want that to happen. Let me see here.
That sometimes does have to happen. I mean, if somebody gets brought to us at 2 o'clock in the morning, as we're getting ready to, we've already packed up all our gear and we're leaving, we will call an ambulance and have that person transported if it's necessary. But we would prefer not to do that. We would prefer to help people come down safely, get home safely.
If you feel that you're being threatened, you're being emotionally threatened by a patient, like they're talking stuff that you really can relate to and you don't feel like it, switch. Get somebody else to work in there. A lot of times we have patients that are doing acid that have just lost somebody. If you've lost somebody and you can relate to that patient, go in and work with them, let the person know that's working with them now that, hey, I can help.
Never did that.
Pardon?
They never call me in for patients.
Oh, well,
We use Bob when they're yelling, Jerry!
basically, you want to try to
Comes in in a Santa
relate.
suit.
It works.
You want to try to relate to a patient. The thing is, if you see a patient is getting violent and you're sensing it, but none of the supervisors are at your touch, let us know, because we've had several cases where we thought this patient was okay, it was PCP maybe, and this last minute slip, he's like up and running. And we've had our staff get punched in the eye and punched, we've gotten hurt. They can be real violent. Also, what we do is if it becomes to a point where they are violent, but we can, or Kathy's staff can maybe medication, they sleep, and then they're okay when they wake up.
One of the basic things, Steve Anderson, who usually does this talk, always refers to somebody with LSD as an ego with feet, or an id with feet, an id with feet. Their boundaries, as people, we maintain a set of boundaries between us and our environment and the other people with whom we are in contact. When somebody is taking LSD and they're on an LSD trip, those boundaries tend to disappear and to dissolve. So that person feels at one with the floor, the wall, your legs, your fingernails. He could relate to any part of your body, and suddenly he's at one with it. He may be melting into your body. You may look like you're melting into his body. The hallucinations are tactile, visual, and mental, right? And auditory. And what about olfactory? Bob knows a little bit more about LSD effect. Tell him a little more about how LSD works.
Well, a little bit of LSD, like about 100 micrograms, can affect the total perception. We usually don't see too many people that just taking 1 or 2 hits. And those people usually just want a quiet place to sit on the mat. They usually supervise themselves. They need just a little bit of attention. Where it really gets complicated is where some Marine just out of boot camp knows that LSD won't show up in his urinalysis test when he goes back on Monday morning, and he's in the parking lot and some deadhead says, eat one of these, and he says, that's so little, I can eat 10 of them. And the deadhead says, here, I'll give you 10 for half price. And the next thing you know, we got a 6'4" Marine who can do 300 push-ups in there, totally out of his gourd, doesn't know if he's dying, he cannot articulate, so he can't explain to where he is to anyone. The best he could do is scream obscenities that he wants to have sex with parts of your body you didn't know you could have sex with. And may develop into a belligerent where he thinks he's just defending himself, but he'll swing and attack anyone who moves. And in that case, it may take 4 to 6 guys to hold him down. At that time, the head medical person decides the 4 people laying on top of him, and when you go to your first show, There's usually at every dead show, we have training on how to restrain people passively, so 4 people can hold them down comfortably without injuring or hurting them, obstructing their airway, making it difficult for them to breathe, and you don't want to get bit, kicked, scratched, pinched, or anything else that this person is totally oblivious that he's doing it. And at that time, they'll decide, do we want to give them a medication restraint, give them a little 2 and 2, as they call it, out of Van Haldo, or whether the guy is so big and we're so overwhelmed because we got 20 Marines in there that we bring out the leather straps and line them up in a row, or sometimes only one person just needs to sit next to him and tell him that he's going to be okay. One thing when they're under the influence of LSD, you can't ask them 10 questions on the intake form and expect to get answers, because you'll be down to the 5th question and he'll be answering the first. So if you go there and say, what's your name? And this Marine says, Mary Jones, well, take a hint. His name isn't Mary Jones, and maybe you should come back in 10 or 20 minutes and ask him again. Usually about an hour later, you'll be able to tell whether or not he can answer the questions. Occasionally, if they're without friends or